Welcome to the Shared Practices podcast. This is season 4, where we're focusing on case acceptance. And we have with us a guest who is well known for his dental food.
Let's not talk about nachos in this episode.
Whatever.
Come on.
I was flying through Philadelphia like 2 weeks ago, and I tried my hardest to get nachos just in honor of Paul Goodman in the airport. It was 7 a.m. and I like walked up and down and tried to find somewhere that was serving nachos at 7 a.m. and I couldn't. So I feel kind of cheated out of the experience.
Oh my goodness. Well, we have my dental therapist on today, Paul Goodman. He's been a big mentor of mine, long before practice ownership, but especially in these early parts of practice ownership. He's been somebody that has been, generous with his time with me, and I've been picking his brain quite a bit. So I've been very thankful for his contributions to my career. And I'm excited that we had him on today. He definitely killed today's episode. He did so great.
Like this is exactly the kind of content that I was hoping to get in this season, which was very like nitty gritty role playing, like how to talk about things in the best way possible, because we're just it's so beaten into us to like use dental terms and say things the right way, especially like in my residency. I just got like grilled nonstop on saying things the right way, quote unquote, which is all of the dental terms that I now need to unlearn and never use again. And so Paul does a great job in this episode of really driving that point home and providing language and providing specifics to help us with that. So
I think there's two main things I took away from this episode that I want people to keep an eye out for, or an ear. First is mindset. Paul's philosophy towards implants and his mindset in and around them has a lot to do with his case acceptance. Second is his dialogue. He just offers so many great examples of specific things you can say, a lot of which I've implemented, and I'll talk about that in the outro. But, I think the mindset and the dialogue are two things that Paul really brought in this episode that can be taken away.
Well, let's get into it with Dr. Paul Goodman.
All right. I'm very excited for an episode today. I have Dr. Paul Goodman on the show today, and Paul and I, we've mentioned him a lot on the show. He's only actually been on the show once, but we did the Ownership Accelerator together. And Paul's he has multiple expertise, so to speak. He's a very well-rounded individual. He owns multiple practices. Now you have 2. And he does a lot of implant placements, and now he does implant teaching. And then he's also kind of a buyer's representative and a broker. So I could spend a whole hour talking about what Paul does, but I think I'd rather just kind of focus on our episode today, which will mainly be about implant case acceptance and kind of managing implant consultation, something Paul is very good at. So how are you doing today, Paul?
Oh, I'm doing great, George. Thanks for having me on. Thanks for that nice intro. We should do this every day to lift my self-esteem. So
I'll give you a call in the morning and go over how I would describe your occupation.
After I get to the office, I have 5 complaints sitting on my desk. People upset. So you guys do an awesome job with this. I mean, what you do for young dentists is amazing, and I'm honored to be on and share.
We did the course together. We did the Ownership Accelerator. Great course. It's done very well. And ever since then, you've kind of been my, mentor, so to speak. You call yourself my dental therapist, which I appreciate. But I do want to take a few minutes and publicly acknowledge how thankful I am for your influence in my career very early on, and how nice it is to have someone like yourself to talk to. As you know, I utilize that luxury more than I should. And I've appreciated learning from you a lot. And so I do really appreciate your insight.
Oh, thanks for saying that, George. And I mean, it really is my pleasure. And one of the catchphrase I have with my GPR residents is treat special people special, and you really are a special person to me. I mean, in getting me to kind of do the Ownership Accelerator with your deadlines, your George deadlines of we need it done by this time. I actually was great, and it forced me to put together a lot of great thoughts, and I'm just proud of what we did there. And I mean, I've gotten such great feedback on it, and I think I know what you're doing and kind of paying it forward to your young dentists. So I'm happy to be your nacho dental therapist on call. It's just some texts and emails and Facebook. So no problem there. I actually really enjoy it.
Well, good. For everyone in the audience, I'm sort of using Paul quite a bit. I'm following a lot of things that he's done in his career. And so he's been a great resource for me, not related to the topic of this episode, but in this episode, we're more talking about implant consultations and case acceptance. So can you kind of talk about your background in implants in your practice and how it's really changed your practice?
I mean, I think origin stories are important. So I graduated from Penn in 2002. My dad had a dental practice with a partner. In dental school, I would say I wanted to be, or prior to dental school, I wanted to be a doctor, dentist, or a lawyer like George Clooney from ER, or Tom Cruise from A Few Good Men or a dentist. And those were sort of my, childhood dreams. And I, really wanted to be a dentist because I loved my dad's lifestyle. He got to help people, work with people. And he was just, fantastic dad and mentor. And he never pushed me into doing anything, but he said, being a dentist, you get to be your own boss. And I really, really liked that part of it. So I went to dental school, but in dental school, I didn't really enjoy a lot of the clinical arts and crafts stuff like restorative dentistry. I enjoyed talking to patients. I enjoyed doing larger cases at Penn. I was lucky enough to have an advanced group leader, Peri-implantitis Howard Freeman. So I got to do some big crown and bridge cases. But I found, having to do all these different procedures kind of just, I didn't enjoy it. I'd do a filling one appointment, denture the next appointment, root canal. So I said, I want to do a GPR. My dad encouraged that. He said, he did the Air Force. I don't know, back in the day, dentists of those generations, they did the military. What he said about the military was, he said it was a great experience, but he had no one to help him. I mean, he just went into the Air Force and he just did dentistry. So he did get to practice a lot, but he didn't really get a lot of mentorship. So he saw this GPR that, hey, I could do this before I come back to my town. And in my first year's GPR, first 3 months, mine was unique, and it still is, because they encourage general dentists to learn how to place implants. So to you, George, that might be not a big deal because you're a young dentist, but as a medium-aged dentist in 2002, that was a pretty big deal from the political, I'll call it the political implant drama that was going on. I don't know if you're familiar with what the implant life world was like back then.
Yeah, I'm familiar with the timeline of, how it was originally not accepted, and then, certain specialties were fighting over it.
So typical dentists, they just tell people what to do, even though it's periodontists. It's actually kind of laughable because initially oral surgeons were the ones that were only allowed to do implants. Periodontists were excluded. Then the periodontists formed their own thing. They did it. And then, they started that to trickle down to general dentists, but it was like, hey, general dentists shouldn't do this. They're not trained to do it. But my GPR, the program director, was just like, we're going to teach you what to do. It's a great place. All the specialists that taught there were on board with helping us. And 3 months in, I placed an implant with a periodontist. And when I say placed an implant, I just watched him place an implant, right? So, he was a great guy. But I don't know. Have you ever been taught by specialists before, George?
Yes.
They're wonderful resources, but they're so good at what they do. It's hard for them to teach someone who doesn't know anything about what they're doing how to do it, unless they're in a specialty program. So this periodontist, wonderful person. I still am friends with him today, but I only did about 2% of the procedure. If 2% is making the patient numb, right? And he just did the rest. But when I saw it, I was like, this is what I like. I mean, you make a hole in the bone, you put in this titanium root. To me, I found it to be very straightforward. And I said, I want to learn about this as much as possible. So I was someone who didn't really love anything about clinical dentistry, to loving implants. And I stayed there as a chief resident and actually as a hospital fellow. So I did a multi-year GPR, and I got a chance to place and restore 150 implants over that time, which was an enormous amount for someone back then. So I wanted to bring this into my dad's practice. So I said, okay, I'm going to leave this program. I got all this training. I love being in the hospital. I learned a lot about managing people during that time. I also learned a lot about how to talk to patients. Went to my dad's practice, and I was placing implants. I was doing one of the things about our general practice residency, and maybe I think most are like this. It teaches you how to be a really good decision maker, and it teaches you how to say, this is something I can or can't do, right? So that's it's difficult, right? You see, as a practice owner, you have something in front of you to do, and you're thinking, should I do this case or not do this case, right?
Yeah. Of course.
And what is your parameters for that? It's not easy, right? Because, hey, you have an endo case. Should I do it? Should I refer it? Am I a baby for referring it? Should I try it? That's not an easy thing to do. So what I got to do was doing 150 implants with specialists helping me in general dentist. I was able to find out what was the easy, medium, and hard cases. And when I went into private practice, I only wanted to do the easy and the medium cases and refer out the harder cases. So I incorporated that into my dad's practice, but then I've told you over the years, we brought an in-house periodontist, and that went from 2006 till now 12 years later, where we have a periodontist come on Mondays. I'm planning a lot of cases. When you do have an in-office specialist, you get really efficient. You know what efficient is another word for, George?
No.
Lazy. So you get efficient / lazy. So if someone says you're lazy, you say, I am very efficient. So what happens is, when you have an in-house specialist and you see how quickly they do these procedures, and you see as a practice owner, there's a lot of things you have to do, like referee fights, why is somebody crying, what happened with this patient. We now kind of share these cases, and we kind of operate as this dual-headed implant, not monster, but dual-headed implant superhero, where I plan all these cases, talk to all these patients, know exactly what goes on, and then I'm able to have him do the surgeries, me restore the cases, or have my associates restore the cases. But along the way, I'm still teaching dentists on a regular basis how to do simple implant cases in my courses, and I'm teaching my associates that. But it's kind of part of the larger conversation of being a dentist and practice owner. Your goal is to hopefully train people to do the things that you used to do, right?
Exactly.
So if I had to place all the implants in a practice, I would place more, but our practice would do less, because when you have a specialist in-house, they're able to do lateral window sinus lifts, soft tissue grafting. So to me, I love practicing this way. I mean, I love having multiple dentists in one place. We have a second location. Patients, I mean, one of the things I encourage people to do with learning how to place implants in our courses is do the ones that they feel comfortable doing, because patients love not leaving your office, right? I mean, they barely like coming to your office. Would you agree?
Yep.
So it's like, people are like, patients don't want to leave my office because they like me so much. No, it's just because that's the only place they can get up the courage to go to. So that doesn't mean you shouldn't refer cases, because you should know what's in your comfort zone as you expand it. But it's just really nice when you say to a patient, hey, we can take care of this in the same location. It keeps up their momentum. We can kind of talk about that with the case acceptance. But that's sort of my implant story in a nutshell, along with teaching with the Hyacin courses. I don't know, are you familiar with the Hyacin implant company?
Yes.
So they're interesting because in 2007, remember, this is before Facebook. This is before all the online Facebook groups. I mean, Dentaltown was around. When they brought their product to the US, in Korea, all dentists place implants, general dentists, specialists, because there's very competitive dental environment. In the US, when I asked my mentor and the person who I teach with, Dr. Alex Cho, he's from Korea. He's a periodontist. He's an amazing dentist. When we were teaching in 2007, he says, American dentists, we just have it too good, because you don't have to place implants to be successful. This is, let's say, back in 2007, right? In Korea and other countries, general dentists do a lot more. So when they brought this training program, which they call the AIC, over to the US, the model was to teach general dentists under the guidance of like 2 or 3 experienced dentists. And that's what I did for years and still do now. I'm a very transparent guy. You could see through me, George, if you see me. I'm just joking. But Hyacin, as a company, I've had a lot of challenges with some of the things they've done with their customer service stuff. But from their message of teach general dentists how to do implants, I've loved that, because once I started doing that, it gave me the platform to help general dentists learn how to do it in their office. And I've probably done that course, 50 times over 10 years. And it's made some great friends and relationships doing that.
Yeah, and I can comment on the just in-house specialists. I do not personally place implants in our practice yet, but having an in-office specialist has really made it a lot easier for patients to do more implants. I think we're probably doing about twice as many than we probably were before, just having that in office.
Yeah, it's maximum efficiency. You cater to the patient's laziness and their momentum, and just put yourself in the patient's shoes. You would enjoy just coming to the same location, right, to do the same work. So, I think that, and that doesn't mean we still refer out cases. So anyone listening, that doesn't mean we do everything. So a person who wants to be sedated, we don't do it. It's okay. I know some people love sedation. It's not what we do. If anyone wants to see our office in PenningtonDentalCenter.com, it's a cool house office from like 1940s, but it's not set up like a giant, we only have 5 operatories. So if someone needs to do sedation, we just can't offer it in our office.
So now, Paul, the big part of your role in your office is talking to patients about implants. So where are you guys most getting is it through hygiene that you guys are getting your implant patients, or are they coming in to your office specifically for implants?
That's a great question. And there's a few answers to that. So for single tooth implant replacement in the back, which is what I teach a lot about, really what does comprise at least 70% of the cases, our patient demographic is most of the implants come out of people ages 60 to 80 years old who have kept their teeth for many years. Great on them, gone for bridges, crowns, root canals, and the most common reason they need an implant is that the base fractures or the root fractures. So I think they should be, I think as dentists, we should make them feel proud, because what's crazy? If you drove a car for 50 years and you need it replaced, the mechanic wouldn't be like, hey, George, I can't believe your car failed, right? I mean, they should say, good job keeping this car in business and shape for 50 years. But us as dentists, and that's part of my message with talking to patients, talk to them like people, not other insane dentists. that they come in and now, okay, they've had this root canal done for many years. It's successful, but now the root has fractured. Maybe we didn't expect people to keep teeth this long, so that they come out of hygiene visits or our existing patients. The larger cases are actually brought in. We do a couple marketing things. We do New Patients Inc., which is a direct mailer. We do search. I mean, everyone does this, search engine optimization, things of that nature. Those are new patients who come in who maybe haven't seen a dentist for 6 or 7 years, older, and they had a partial and a bridge, and now that's breaking down. So that's one segment. So we have our existing patients, single teeth implants in the back, root fracture, I call base fracture. New patients who come in through a marketing program who usually have larger cases. And then we have a lot of our own patients who, have had a lot of dental work done. And I used to give this lecture, George, that there's 2 types of patients that we'll treat: people who have no teeth or people who are about to have no teeth in these large cases. So I think a lot of dentists, and maybe some of your younger dentists, might think that, people show up without any teeth, they have dentures that they hate, and they want implants, right? Is that maybe a common thought you might have, or a young dentist has?
Yes.
It's to me, I would think the same way, but it's not. It's inaccurate, because those people who've had dentures for a while, they've adapted, and it's rare for them to wake up 6 years into having dentures and say, "Today's the day I'm going to get implants," right? But the people who fall into that category are people who have, half of their teeth, some partials, some restorative work. And you look at them broad picture and say, "Hey, Millie," because, that's probably a common name for someone ages 60 to 80. "Hey, Millie, now is the time that we talk about your next set of teeth," right? What's going to get you through for the rest of your life, whether that be 5 years or 15 years. And those are the patients who go from teeth to implants or implant retained dentures or fixed cases. But what's interesting, and what I'd like to point out to your listeners, and I've learned myself, it's very difficult for them psychologically. I mean, imagine having teeth for like 72 years, George. Now someone tells you you're not going to have teeth. Like, that's not going to have natural teeth. That's a huge psychological barrier to get over. And functionally, they do really bad with dentures because, I'm not that mentally flexible right now, and I'm 41. Do you think these patients who are 72, they're not going to be able to live the rest of their life with dentures? I mean, it's going to be something that's too difficult for them to process because they've been chewing with fixed teeth for, I guess, 65 years. And these are people who are really good candidates for full implant cases, which I put into 2 categories: fixed and removable. Removable overdentures or fixed cases, teeth that stay in all the time, teeth that you can take out at night, teeth that you have to meticulously care for like a fancy car, teeth that you could wash under your sink, which you still have to take care of, but it would be fairly easy to wash your teeth under the sink, right, George?
Yeah, pretty simple.
Yeah, so I learned, wise people learn from the mistakes of others. I used to do all these fixed cases back in 2005 and 6. And I was like, I was like young like you at 27. I'm like, "Hey, you got to have fixed teeth, Mrs. Smith." And what I realized was, if people lose teeth, this is a great podcast. And if I'm talking too much, just jump in at any time, George. But
no, you're good.
People lose all of their teeth for usually 2 reasons: a lot of decay or a lot of bone loss. A lot of decay or a lot of bone loss. Interestingly, they don't usually have both. I mean, you haven't been a dentist that long, but it's rare for someone to have a lot of decay and a lot of bone loss in general. Not impossible. So the people who lose their teeth for periodontal disease reasons, bone loss, bone shrinkage. If you want a quick tip, I don't say bone loss, I don't say periodontal disease, I say bone shrinkage. Those people are not good candidates, in my experience, for fixed implant cases. Because why do people lose their teeth due to bone loss or bone shrinkage? Usually it's behavioral, right? Like, they have not taken good care of their teeth over the years. They haven't been taking good care of their bone. So when you give them a fixed implant case, which I liken to a fancy sports car, like, what's your favorite sports car, George? Porsche, Mercedes?
Wrong person to ask.
Yeah. Well, we pretend like sports. Here's an example. Here's a perfect example. I just told this to a guy yesterday. He was getting it. Exact perfect example. I'm 41 years old. I'm a co-owner of a 4-year-old and a 9-week-old. And we went to get a new car. And I was going to get one of those BMW X3, X5 things. Have you seen those?
Yeah, the little mini SUVs.
Yeah. And then I said, because I live in the cities, then I said, we do not take good care of our cars. I park it behind my place right in Center City. I don't know if we have all these goldfish in our car, not real fish, but those crackers my daughter eats all the time. I mean, they're just strewn about the car. So I say, you know what? I should get this. I'm not a car person either, but I got an Acura RDX, right? It was the next level down from that in price, but not about price, also in care. So if you get a BMW, you usually can't just go to any oil change place, right? You got to go to the BMW place. So the maintenance of BMWs or Porsches or Mercedes, the maintenance of fixed cases, it's very difficult on the person driving it or eating with it. And I've learned the hard way that if these patients do not take care of it, the cases are going to have problems long term. And I have cases I've transitioned from fixed to removable, which is why now I love the removable implant locator overdentures. They're like my favorite cases to do. There's a lot of room for getting it right. Patients love them. If they have any problems with them long term, you just get to replace the denture part, the least expensive part. But guess who doesn't like removable overdentures, George?
Patients?
No, patients love them. Guess who doesn't like them? The other person in the room. Who's the other person?
The spouse?
No, spouse, they like them. The dentist. Dentists don't like them. So dentists say to me, why would you do removable teeth for this person? They should have fixed. I'm like, there's just a 77-year-old grandfather who goes fishing and picks their granddaughter from nursery school. I'm going to give him this fixed Mercedes. He didn't take care of his regular teeth. So it's always about the teeth part. So when you do a removable overdenture, I'm just going to use an example. I know your listeners will be like, whenever anyone says a price about dentistry, okay, if I told you what I charge for a crown, I'm not going to tell you, okay, George? All the listeners do this. That's too high or that's too low. They never be like, hey, that's a normal fee, right? No matter what the fee is, right? If I say I charge $600 for a crown, half your listeners will be like, that is way too cheap, right? Half of them will be like, I can't believe it's $600. So I'm just going to use an example for the overdenture part. You've seen a U-shaped overdenture that snaps into like 4 locators or 6 locators.
Yeah.
And then you've seen a fixed case made out of zirconia or titanium and acrylic, the screw-in job, right?
Yeah.
The screw-in part is to replace it's probably like $12,000. The overdenture to replace is probably like $2,500. So if you're setting someone up for success, do you think you're setting up more for success if you give them a $2,500 replacement thing or a $12,000 replacement thing?
So I see where you're going with the BMW analogy, where the parts in the repairs are much more expensive.
Exactly. So now they might be 87, right? I did a case in someone who was 63 at 74. A lot of it's breaking down. I posted this in some of the Facebook groups so people could just tell me I'm a terrible dentist. That's my favorite thing. I'm like, hey, I'd like to post a case so you can tell me I'm a terrible dentist. So the dentist I posted, I said, hey, if I was going to give you fixed teeth for 11 years and you're going to have 11,000 meals with, that's another one of my tips, 1,000 meals per year. So if someone says, hey, my crown broke apart, or, my crown failed, we don't say failed in our office, by the way, way too dramatic. We just say that replaced. So if you don't say fail in your office at any time, it's just going to bring up the morale. So when someone comes in with a bridge and it has decay underneath it, and they've had it for 17 years, don't say, oh, hey, Mr. Smith, your bridge failed. You're a failure, right? It's kind of bad for morale. Say, oh, hey, we have this situation. There's a cavity underneath the bridge. We need to replace it. Even though it sounds the same, it's a different feeling. But getting back to these implant cases, so I posted this and I said, if I gave you fixed teeth at 63 and at 74, I was going to snap my fingers and the whole thing was going to fall apart. Do you think it's worth it? All these dentists said, of course, it was not worth it, right? Except for a few. Guess who thinks it's worth it? The person who I did it for, right? Like, he got to live 11 years of his life with teeth that didn't come out of his mouth, 11,000 meals. And now we got to shift gears and make him a removable case. So one of my messages is about implants. It's like, don't be so dramatic about stuff, right? Like, have you heard of this thing, George? Are you sitting down over there? Because I hope you're sitting down.
Yeah, I'm sitting.
Yeah, I'm sitting too. You know what they say? I say, hey, everyone, we should do more implants, talk about implants, and, talk to our patients about it. Because instead of bridges they say, someone raises their hand. One time in band camp, I saw an implant get peri-implantitis. Have you heard about this monster, peri-implantitis?
Yes.
So only dentists could be so negative that when you're talking about such a great thing, you're bringing in this thing that's unlikely to occur in the majority of cases. So first of all, when they talk about peri-implantitis and they're doing the studies or research stuff, they're rarely talking about the single back tooth implant, right? They're talking about large cases. So this case that I did got peri-implantitis, right? It was like we did 5 implants, immediate load case in 2005. Now in 2016, 17, 18 time, we have to transition it. So it got peri-implantitis over the years, okay? Bone loss, some implants were lost. So I have a question for you, George. You're a young dentist. Was that case successful or unsuccessful?
Well, I think it depends on the expectations of, everyone on board, patient and you.
So how about if you were the patient? Would you think it's successful or unsuccessful?
Yeah, I mean, it's hard to say because I need to know what was my expectation, right? As a patient doing that treatment, how much was I expecting it to last?
I mean, what happens is, the reason I use this, because it's such a good example, and this is actually a genuine question. This isn't even one of my questions where I'm trying to, get, why do we replace cars every 10 years, right? Every 10 years, we get a new car, sometimes sooner, right? But let's just give it 10 years, right?
Mm-hmm.
Does anyone get furious that this happens?
No.
Everyone understands you just do this. You eat every day, you drive a car every day, and you get a new $40,000 thing or a $30,000 thing or a $50,000 thing every 10 years, right?
Yeah.
So when you do these cases, and this case that I did in 2005, thinking it was the best thing that I could do, right? I'm hoping dentists are thinking this is the best thing they can do, or they've talked with the patient. This is 2005, not 2018. This patient would take this tomorrow, every day, over again, over and over and over again, because it changed his life, helped his career, got him healthier. And now that it's different when you're 74 versus 63, right?
Yeah, big difference.
So now he's getting a removable overdenture. He likes that too. So my message in talking to patients is, don't be so dramatic. Don't focus on the negative totally. Be responsible, but don't focus. I mean, I don't know, watch this, George. One day I do hope you come to Philadelphia and have nachos at Alves with me. I will pay, okay, right? Dennis and Recipe, I will pay for all the nachos, okay? But George, I go to Alves. It's my favorite place on the planet to have nachos. I just want to tell you this. One time someone went there and they went home and they felt sick and they said the nachos gave them food poisoning. Do you still want to have nachos there?
No.
Right? But what if I told you that 12,000 other people had nachos and did not report food poisoning? Can we have nachos there?
Probably.
Right. So that's just life, right? I mean, in general, look at cases and say, what's the most likely thing that's going to happen? Is this and learn from me. Is this person going to take care of the thing that I'm doing? Fixed implant case. Are they not? Removable implant case. One of the crazy things to me is, how people we're kind of past this with the bridge versus the implant. Even the patients know they don't want the bridge. Honestly, patients know this by now. Dentists. So, when people lose a tooth, right, and they get a bridge, probably that's one of the worst things we can do, because people don't lose teeth by accident in general, right? Would you say?
No.
So if they've lost their one tooth, we've now made it exponentially harder for them to take care of the 3-tooth replacement with a bridge, because now we've given them more chance for getting a cavity. But this is the best we had at the time. I'm sure if we're podcasting when you're 70 and I'm 83, George, we'll have something better than implants. But at the current time, I think my message with talking to patients and managing their expectations like that patient is to not be too dramatic and not focus on a small thing that might happen. Because I give this I'll give you this as just a good tip for your consults with your periodontist, is single teeth implants. So when you talk to a patient about a single back tooth implant, right? You guys do those in your practice. Let's just talk about a general number 30.
Okay.
You're talking to me, hey, Paul, you can do nothing. You can do a bridge. You can do a partial. You can do an implant. And if I said, how long does the implant last? What are you going to tell me?
On average, around 30 years.
I like that. It's a number. But what if you said, I'm not there yet, but what if you said to every patient that got one implant in the back of their mouth, Paul, that implant will last you forever, okay? Dentists are probably just freaking out as they hear this. How many people out of 100 would you have to apologize to?
5.
Right. So maybe we should say implants last forever and apologize to those 5 people. I'm not quite there yet, but my message to your listeners and dentists are, could we focus on the 95 that go well? I mean, if this gets us to a point, people ask me all the time. I get all these messages from across the country, not just you, George. I mean, from my own friends. Paul, what should I do in this situation? Something I did has not worked out well. An implant has failed. Somebody doesn't like their partial. Filling I did fell out. Crown broke. And they always say, what should I do? Right? They ask me. I don't know how I became this guy. I'm glad to be this guy, because it's an easy answer. I tell them the same thing every time, right? I say, what would you want done if you could be in the Fight Club or Matrix or cloning, and you were the patient and the dentist. So I'm going to give you an example, George. I do an implant for you. I say it's going to last forever. We do the implant, we do the abutment, we do the crown. The abutment and crown are fine, but the implant gets loose and falls out on the floor. And you bring me your whole thing, and you spend $4,000 on it in 2011. And I said it was going to last you forever. And now it's 2019, okay? What would make you happy? All your money back, half of it back, or none of it back?
Half.
Half? Just give them half the money back then. Here's a good tip. You getting all these. Being a practice owner is not so easy, right, George? A lot of questions every day, a lot of stuff going on, right?
Yeah.
So just have go-to things in your mind. First of all, how often does stuff come into your office where people are really unhappy with what they've done? It's fairly infrequent. But when it does come in, it's annoying, like a rock in your shoe, right? Or stale nacho, very, very annoying. So just say, hey, Mrs. Smith, how about this? Just go with what you think is reasonable if you were the patient. Person comes in, crown breaks, it's been done 3 years. Hey, Mrs. Smith, how about this? Insurance covers crowns every 5 years. Yours only lasted 3 years. I would be frustrated too. How about this? We'll do a new crown at half price. How does that sound? And then just don't say anything. Of those 10 problems, 7 people, what do you think they're going to say?
Sounds fair.
Sounds great. Then you're done talking. If Mrs. Smith says, you should do it again for free, then think, okay, is this Mrs. Smith? She's been a long-term patient. She spent a lot of money in the office, blah, blah, blah. Maybe I will do it for free. Is this a new patient who I don't really know and I don't want to do it for free? It's your office, your call. There's no real wrong or right answers. But the only sensible way to do it, George, the only sensible way to talk to a patient about it is to start off with what would make you happy if you were the patient.
Yeah.
Put yourself in the patient's shoes. Look at what's happened. And the reason why I think this helps with case acceptance is because I think we should be unbelievably positive about implants. They're so awesome. I mean, they work so well. They help so many people. I think patients like them more than dentists. I think dentists in dental school, they brainwash you that the natural tooth is the best thing ever. I don't know why they tell us this. We have 28 of them, right? So I have 28 best things ever in my mouth, right? One of them goes down. I got 27 left, right? Do you know I did a poll on my Nachos group? It was hysterical. Dentists love to think they're scientists or they're rational, but they're nuts. They're not rational at all. So I did a poll. If I extracted your tooth and gave you an implant, right? We all know implants are over 90% successful, right? So if I made it specific. I'm going to come into your office. We're going to take out your number 20. We're going to place bone. We're going to let it heal. We're going to place an implant. Every dentist will admit that is over 90% successful, right? 9 out of 10 chance, right? That would work out well. Would you agree?
Oh, yeah, sure.
Okay. And then you've been a dentist for a short period of time, but the back teeth implants that people get, do they usually say they act just like their natural teeth, or they don't know which one it is, or thanks for doing the implant? That's what my patients say.
Yeah, not many complaints.
Yeah, whatever. But food impaction. I got food impact. What about a food trap? I don't know. Clean it out with a soft pick, right? I mean, I got a food trap between my 5 and 6. Yeah, I'm not doing a crown with my brother for it. So they like the implant. We've agreed that it works out 9 out of 10 times, right? Here's my offer. I will give you $100,000 and do the implant for free if I can come into your office and extract number 20, right? 20% of dentists said they wouldn't do it. Do you know how insane that is? Do you know how much brainwashing has been done to people in dental school? They would not. You could change your life with $100,000. You could pay for college for a child. How about this, George? The dentist, like, I'm not in it for the money, right? Just they're in for the love of the dentin, right? It's like, honestly, how about this? Donate it to charity if you want, right? But I'm telling you that I can replace your natural tooth with something that works 9 out of 10 times. And even if it doesn't work that one time, just so you know, you can still redo it. And 20% of dentists, it's one of my biggest polls. I'm trying to get to 1,000 votes because some dentists are, of course, like, the other side dentists, like, can I get a 2-for-1 special? I'll let you take out 2 teeth. So they don't care about their teeth at all. They just want money. But I just think it's funny how the natural tooth, and I guess since my training in implants when I was young, I just found implants to be good like teeth. I mean, I don't know, root canal and crown, that's tacos. Implants are nachos. We're fighting so much over tacos and nachos. It's pretty dramatic.
While I was recording these ads, I stumbled across a post of someone who's doing a startup right now and wanted to give a shout out to Design Ergonomics on Facebook. So she says, "Hi all, I'd like to give a shout out to Victoria Paquin from Design Ergonomics. I started working with her for my practice design, and she is incredibly helpful, responsive, and knowledgeable. If she cannot give you an answer right away, she will research it and call you the next day. You should absolutely call her if you are doing a startup." So just to further dial in this shout out, I've got here Victoria Paquin's phone number. So her direct line is 774-704-5252. Once again, that's 774-704-5252. And we'll have that in the show notes. Her email is vpaquin, VPAQUIN @desergo.com. When you're designing a practice and trying to build this startup from nothing, you want someone like Victoria in your back pocket who's going to be responsive, happy to help, researching things, looking things up for you, rather than someone that you can't get a hold of and isn't responsive and is dragging their feet. This is the kind of team that you need to successfully launch a startup. Reach out to Victoria or anyone at designergonomics.com and make sure to mention the Shared Practices podcast for your maximum discount.
So Paul, let me kind of shift gears here.
Sure.
I see that, it's important, that we're talking about kind of the mindset of the dentist in the consultation and really buying into the treatment and how awesome it is and how that'll allow you to really, talk to the patient successfully about it. How do you handle the patient that I think it's easy for me when they're concerned about the missing tooth? They don't like that it's missing. They've got it grafted and just haven't gotten the implant yet. Like they're already kind of halfway there. So can we do a little role playing?
Sure.
So let's do, I'm the patient, you're the dentist, and you walk in. I've been missing number 30 for like 20 years, and it's never bothered me. I got it pulled when I was in college, had a toothache, just got it pulled. Now I have money, I'm successful now. And, I could get it replaced, but it just never bothered me. How would you kind of approach that conversation?
Yeah, it's a great question. I mean, I use the same technique, and John Coyce is really fantastic. I mean, he's just one of my idols. I got to lecture with him this summer. I mean, I learned a lot from when I was your age. So I sat in a lecture in the Hinman in Atlanta, and he said, all conversations you start off with like, hey, this is what happens if we do nothing. Patients don't accept solutions to problems they do not have. So you don't have a problem because it's never bothered you. So I always start off by saying, I am a pretty jokey person. I do it the same way with my patients. Say, hey, George, this tooth is missing on the bottom right, never like number 30, no dentist talk. I just want to review with you what will happen if you do nothing. And then this is the magic. Hey, George, even if you decide to do nothing, we can still be friends. And I make that joke for two reasons. I mean, A, no one wants to be friends with their dentist, right? And B, everyone's had some sort of relationship thing in their life where someone says, oh, I don't want to be your boyfriend or girlfriend, but we can still be friends. And you're like, that is not a good option, right? That's like, you're trying to make me feel better, but it just lightens the moment. I say, hey, here's what happens, George, if you do nothing. These are my 9 magic words to millions of dollars. I'll give it to your listeners is tooth above can fall down. Fall down is the word, the phrase I use, because you don't want to say super eruption, because you don't want to, patients don't care about dental terms. So you have to talk to them like people, not other crazy dentists. Tooth above it can fall down, tooth behind it tip over, bone shrink, the other teeth break. So those 9 words: fall down, tip over, bone shrink, other teeth break. If you say those 9 words, and just those 9 words without any others, your implant case acceptance will skyrocket. I mean, what's happening is you're not setting up why it's a problem. We're just trying to give someone a solution to a problem they don't have, like Coyce says. So that's how I start off. And then I say, is that a concern for you? So if you want to role play, George, I say, tooth above it. Maybe I'll use a mirror to show you a little bit. If you're using an example, George, right, where it's been for a little bit of time.
Yeah.
So then you have this on your side because you're going to point something out. One of those things has happened, right, to someone who's missing a tooth. Super eruption, which is fall down, tooth behind it tip over, mesial drift, bone shrinking, other teeth break. So I say, hey, George, see this tooth tipping over? Are any of those things that I mentioned, those 9 words, those 4 things, are any of those a concern to you? So I ask you, are any of those a concern to you?
No.
Okay, so then I say, no problem. Just like I said, we could still be friends, and we'll just, see you in 6 months, no problem. But do you want to know why you said that to me, George?
Well, I just wanted to see what you would say.
Yeah, because you're being intentionally contrarian. That's okay. I don't mind. But if you say that to 10 people, you know what 9 people are going to say? Oh, yeah, I don't want those things to happen.
Yeah, no, I agree. And you're never going to, make somebody want a solution for anything.
Oh, yeah. I mean, people are nuts. I mean, if they say no, I'm saying, okay, no problem. I mean, but what I'm saying is if you do that to 20 people, 17 people are going to say, oh, geez, I don't want that to happen. Of those 17 people, half of them are probably going to get an implant with very little resistance. So then I talk about the options. Removable thing comes in and out. It doesn't affect the bone shrinkage. That'll still happen. Other teeth breaking. A bridge, I say that was what we did. I don't knock bridges, so to speak, but I said bridges, are what we did in the 90s before implants, or 80s and 90s. Problem is, we have to, I don't say cut down, but I say we have to prepare, which does really harm the other 2 teeth. I mean, I have a question for you, George. We'll put role play.
Sure.
I come to your house and I steal your number 30 and I'm never giving it back. And you can live the rest of your life with one of 2 options, nothing or a 3-tooth bridge on 29 and 31. And I said this to dentists. I had 10 dentists in an implant course. I said, to get to lunch, because everyone loves lunch, there's 2 doors. You can walk out the door of nothing, or you can walk out the door of a 3-tooth bridge for the rest of your life. So I can prepare, cut down, harm, damage, which is what we do, 29 and 31, to let you chew on number 30, or you can leave the space be. Guess what the dentist door they walked out of?
Leaving the space?
Yeah, what would you pick?
Probably the bridge.
You would pick bridge. Now, I would say that's because you're young. So I'll say to you, because this is now dentist to dentist talk, what benefit does the bridge do over nothing?
Well, okay, I don't want to get too technical here, but I think it also goes into caries risk. And if somebody's had minimal kind of caries risk throughout their life, bridge is probably going to last them a lot longer than.
Yeah, you're exactly right. I say, so, there's always people say, dental school doesn't teach us how to talk to people, George, at all. But you know what it does teach us? Weird terms. Because in dental school, what did they call the tooth that did not have a restoration? So if they said, hey, this tooth does not have a restoration.
Virgin.
Virgin. So this is what you're saying to your patients at Tuesday at 10 a.m. Hey, Mildred, you don't want to touch the virgin tooth, right? She's 80. Right? This is normal, right? So unrestored tooth. So you actually are 100% right from a dentist to dentist perspective. But the thing that I believe that you would have to worry about is you might live to be 95 years old, and breaking that root because the tooth is bridged is a bigger risk. So I'm not saying you can't do that bridge, but we're not putting bridges up against implants in dental school in the right way. They should, dentists, I see dental students still learning how to prep 4 through 6 for a practical in their dental school. And I'm pretty horrified because I can't envision a situation where I would intentionally cut down number 6 or 11 for a bridge for somebody. So when patients are in those scenarios in our office, you can't win them all. But hey, it's like baseball. I don't know, like baseball. If you got 8 out of 20 people with missing teeth to replace it, the amount of revenue you would generate in your office is great. The amount of good vibes you would generate is great. You're giving someone a tooth back. And I don't know, your team likes it. I would say it's rewarding for the patient and team. I mean, you've only been a dentist for a year here, George, but nobody is going to jump up out of the chair after a DO on number 30 and be like, thanks, Dr. George. I really appreciate all the care and skill you put into this. I'm going to go on with my day now. In general, they just get up and leave and like, are we done yet? Right?
Paul, let's bring you back for a second.
Sure.
So I want to go back to that single tooth implant consult. So we've talked about first step is establishing the concern.
Yes.
So we've established concern. Now, how do you approach, so what is the next question in the sequence? So let's just say, I am concerned about those things.
Sure. Okay, good. Let's go over this. Normal people talk occasionally. Let's go over things that we can do to help. That's what I always say. It's good. That's just a good thing you could say to people. Someone has an issue. Let's go over things that we could do to help. One thing is something called a removable partial denture. Picture on your screen, whatever you want to do. These are things you might have seen from your grandparents. They're uncomfortable for one missing tooth. If you do wear it, your tooth won't fall down, it won't tip over, but it's not going to help with the bone shrinkage and the other teeth break. Is that an option you're interested in, George?
Potentially.
Potentially, okay. Another option, 3-tooth bridge, preparing the teeth on either side, the neighboring teeth, risk of getting a cavity later, root canal treatment, which is a problem with the inner part of the tooth. I don't say nerve, I say inner part of the tooth. Is that an option that you're interested in? You might say potentially, right?
Potentially, yeah, sure.
And then say, it's lucky that we've invented implants. And the first thing I say is it keeps a one-tooth problem a one-tooth problem. I think Mark Hyman said that at a lecture I went to. He's a good speaker. So I say keeps a one-tooth problem a one-tooth problem. And here's the reason why implants are so successful. So the reason why implants last so long, it's the implant has an unfair advantage. So 4 things can happen to a tooth: cavity, bone shrink, top part break, base breaks. An implant cannot get a cavity. So when I say to a patient, hey, we're in this situation because of a cavity, this option, this thing, cannot get a cavity. It's made out of titanium. And our patients have done really well with implants because they can't get a cavity. And that's what, I mean, we're usually talking to people ages 55 to 80, right, for implants?
Yeah.
They've had quite a bit of cavity work done in their life. So they're very familiar with the filling and the crown and the root canal. It's rare that you're talking to someone about, see, when we set up these role-playing things, and I do these in my lectures, the problem is most dentists haven't had a lot of dental work done. So we're talking about this hypothetical situation of people who don't have dental problems. In the real world, we're talking to people who've had fillings, crowns, root canals, and bridges. So they're totally aware of cavities being the thing that ruins the work they've had done, right?
Yeah.
So I say, then the implant, one-tooth problem. I have a few small pictures. I don't have a whole dancing light show about implants, that people have in their office. I have a few pictures. And then I just say, this is good. This is good for anything. This is implants or anything in your office. Which option sounds best to you? So, hey, George, at this time in your life, that's a Mark Hyman thing. Which option sounds best to you? What are you going to say?
In my eyes, I would want to know what the implant costs, because based on what you said, it seems like the best option.
Right. And you want to know the cost because patients are like that too. The problem dentists have when they think about this is they don't have a missing tooth, right? So if you were talking about your car or your house or your toilet that was about to overflow, your brain would feel different, right? Because you'd be like, oh, geez, I don't want this to happen. So totally they do say, how much does this cost? And I say, good question. I would want to know that too. For years, I did it myself, but I've trained someone in my office who's amazing, when you can train a team member to talk about money, please do that, because patients think team members are normal and they think we are not normal. So then my team member comes in and she has 3 pieces of paper. She has a treatment plan with the codes printed out, just a list of it. She has a yellow financial form. If you want to put any of this in your show notes, I'll be happy to share it with your listeners. A yellow financial form. Those are 2 main pieces of paper. And I've actually developed this purple implant form, which walks everyone through the whole procedure with codes. So she has 2 copies of this. She has it herself. And she says, hey, Dr. Paul, talk to you about these options. An implant start to finish. I'm just using numbers. These don't have to be my numbers. Implant start to finish is $3,500, George. What are you going to say?
Okay. I mean, I don't know what else. Probably.
You be the patient. You want now implants $3,500. Which of those options, unrelated to money? I say this, I'm sorry. Pretend, George, they're all the same amount of money. Which one sounds the best to you?
So you always say that to the patient?
Yeah, because it's great to say it. Pretend they're all the same amount of money. If I want to make a joke, I say, hey, pretend you won the lottery and you can pay for anything. Or hey, sometimes I make a joke. I say, pretend my assistant's going to pay for everything and you can pick whatever you. Very important. Makes it light. So I'm going to say, hey, George, pretend it's on me. It's on the house. Which option sounds best to you?
The implant.
Right. So you confirm that you did a good job because that should sound best to people, right? Yeah. So then you might go through the implant cost is $4,000. The bridge cost is $3,000. The partial is $2,000. The key is what dentists make huge errors on in patient communication is that if you told me, say you want the bridge, George, right? Say, okay, I want the bridge. That's the middle option of money. Mm-hmm. You got to say it to me. We're role playing.
Oh, sorry. Bridge. Yeah, bridge. I want to.
Okay, George, I'll be happy to do that for you. I just want to remind you that as long as we're clear, the bridge and the implant are not equivalent options. So I hope I did a good enough job understanding that the implant is a better option than the bridge. So if we make the implant is great and the bridge is good and the partial is okay, I do this all the time and have for 16 years. So it's kind of in me, right? But new dentist, you're going to make the bridge and implant seem the same. And then they're going to pick the cheaper one because I would too, right?
Yeah.
So it's key to focus on what happens when a bridge goes bad. So I always say this, hey, George, you ever cut off a failed bridge? Have you ever done that in dental school or when you were in a clinic?
Yeah, I've cut them off.
How'd the teeth look underneath? Awesome?
No.
Right. So tell your patient that. It's like a rock in the forest. Stuff gets underneath there. We don't know. And sometimes when we cut off a bridge that needs to be replaced, not failed, Have you ever seen that one of those teeth need to be extracted?
Yes.
Yeah. So now you're taking a 1-tooth problem, and now it might be a 4-tooth problem. So then we, just to complete the circle for your listeners, we talk about you can pay in full and get a courtesy. And we just offer that option and we don't say anything. Over 50% of our patients pay in full and want a 5% courtesy. If they say, I need another option, we have 2 other options, something like a care credit. They've sponsored me for courses. There's other companies in that space, Lending Club, Green Sky. We have one of those options. And then I work in a practice that's been in business for like 50 years, longer than I've been alive. So it's a little bit old school. So we will offer pay over the course of treatment. Like you can split it up into 3 payments over 6 months. Those are our 3 options to pay. Other than that, if those don't work for you, then you got to wait and get whatever you want later.
I've been impressed with the number of people who have selected the prepay option as well. We have that in our practice, and I think it ends up being like saving a couple $100 for like an implant, and
everybody likes the deal.
Yeah, they like it. They go for it.
That's why I like the in-house membership plans. Now, I was late to the game with the in-house membership plans. I love them. I really missed the boat. I should have put them in earlier. People love that. Love that. If you give 10% off everything with your in-house membership plan, that's all they hear. When you say to somebody, this treatment is $1,500, they're thinking, I can save $150.
Yeah.
So we don't have much we can be nice about as dentists. That is it. So 50% or more prepay, and you see this, and then it's great when people prepay. They don't cancel appointments. You have to make less decisions. It's like, hey, did Mrs. Smith pay for this crown? Should I put it in? Should I not put it in? So that's my Paul Goodman or Dr. Nacho implant consult in a nutshell, or missing tooth consult in a nutshell.
Well, I like it, and I think our episode spent a lot of time on mindset, which I think is good because I think it's really hard as a dentist to talk patients into treatment that you're not totally 100% on board with. I think it's almost impossible. So I think it really helps to kind of think about, maybe rethink of the way that we think of tooth replacement, and really put those options into perspective.
That's why the act. I'm on a mission to have every general dentist in the country, not just through my courses, through any course, place one dental implant, even if they never want to do it again, because that exercise changes how you think forever. Mike Keller, who took one of my courses, has added like $100,000 of revenue. Now he is a practice owner and he's in his mid-30s, so he's set up for this. But he said, totally changed my mindset. So even though I don't place a million implants, now I'm doing more hybrids, because that's the thing. When you do one yourself, it just changes how you think forever. And you young dentists, it's going to be what you guys do. It's going to be, do you see George doing more fillings over the next 20 years?
No.
You're more crowns? No. So it's like, you got to embrace implants with open arms. It's like, I'm going to get a temporary, I don't know if I can get a tattoo, George. I'm not a tattoo guy, but I get a temporary implant tattoo maybe.
No, I've really enjoyed this. And I think that, I agree. I've placed a handful of implants, and I think a lot of the post-op, complication type questions, how much does it hurt, stuff like that. It just is a lot easier to answer, even though I don't place it myself.
Oh, yeah, that's it.
I always say that it's always easier than the process of removing the tooth. That's kind of my line, but I don't know. What do you say when they ask that?
I say, always remember, the good question, I would want to know that too. It's the reverse removal. So we take out a tooth, we put in a titanium root. But the cool part about the reverse removal, or putting in the titanium root, it's a lot more gentle, a lot more conservative than taking the tooth out, which it is.
Yeah.
So, I say what you say. Great. You're becoming a Nacho disciple, George. I like that.
All right. Well, thanks for coming on, Paul. If anyone has any questions for Paul, you know where to find him. Thanks, Paul.
It was an awesome time. Thanks so much.
Okay, George. All right. Have you had your fill of nachos?
I had my fill of nachos before I started this episode. I hop on Facebook and that's all I see. Oh my goodness.
Paul is one of those people. He's kind of like Howard Ferrand. When I first got to Dental Town, I asked people, I was like, who does his social media? And they're like, no, it's all him. Like, I can't believe how active Paul is everywhere online.
Oh yeah. No, Paul is everywhere. And he claims that it doesn't take that much time. And he's like, must be the world's fastest typer, because everything he posts is from his phone, which I can't believe.
This was great. You guys got into some really, really good specifics. And like one of them, there's a lot of mindset stuff for me that was really nice that jumps out to me initially. One is that like All-on-4 is a great endpoint solution for some patients, but it is not the end all be all and requires a ton of care and maintenance from the patient and from the office. And I've got a buddy in Germany who just took a CE course. Gordon Christensen came out there, and he was actually talking about how much damage can be done from all on four cases that are not cared for and maintained well. And then you end up with a patient without good options moving forward. And so him talking about these options and talking about how you need to present an all on four case versus a removable implant supported case, but also that patient who had to downgrade from a fixed case to a removable and how grateful they were for their time with that fixed option. Just a lot of really good mindset ways that, like, things I needed to hear in this episode. So it was therapeutic for me as well.
And I think, I think, one of the things, so Paul is going to come back on the season for a more big case topic, talking about big cases. That's something we talked about after the episode aired. But, one of the things I took away was redefining what we characterize as success. So I had a patient in, like, very shortly after this episode, we recorded it. And, I sat down with the patient and we kind of talked about what would you characterize as success for this specific treatment. And the patient wanted to retreat an endo that I wanted to, remove and place an implant. And so we kind of talked about timelines of what the patient would feel as a success. And I think Paul kind of brings that mindset to this episode of, if a patient's 8 years in a fixed all on four appliance, and for whatever reason they have to downgrade to something removable, maybe that's a success to them. Success and failure is not so black and white like we make it out to be. You know what I mean? Like, root canals don't fail, if it's been 20 years and then they ultimately get infected or something like that. You know what I mean? And so I think it's hard sometimes for us to redefine failure and success. I think we need to do it in the patient's eyes versus our own.
One of the takeaways that you talked about when we were talking the other day was this terminology. So what's the terminology difference here that Paul introduced to your life?
You're talking about the thousands of meals?
Yes.
Oh man, yeah, I love this. I use it all the time now. Yeah, so Paul, he taught me in the episode, he talked about how, a year is 1,000 meals. And so you always talk about, and I have not mentioned the word years again, it's always thousands of meals.
I feel like you've wholeheartedly embraced this terminology.
It's so fantastic. My patients love it. They all laugh. And it just makes conversations about replacing dentistry, because most of the dentistry we do is replacing other dentistry that's been done. So the patient at some point is going to be wondering, like, why do I have to replace this dentistry? So, I think the thousands of meals that they've chewed on it, it just kind of helps them figure out that, like, it's a lot like tires.
Yeah.
And it's like, it makes it fun and positive and like the healthy conversation.
You get to compliment them on like how much they've gotten out of their dentistry. You're like, man, that's awesome. It's like three meals a day times 365 comes out to right about 1,000, in case anyone was wondering on the math there. And to tell them, like, no, you've gotten 15,000 meals out of this tooth. Like, that's fantastic. Like, how do you use it? What have you said?
Yeah. So I had a patient, like, we recorded it, and like the next day I went in and she just had a couple of PFMs that were about like 20 years old that needed to be replaced, some recurrent decay under them. And that's like I always find the hardest time talking to patients about replacing crowns that have been done with new crowns, because it's hard for them to understand exactly why it needs to be replaced and stuff. And so I told them, like, whoever your dentist was, you got to buy them a beer. They got you 20,000 meals out of these crowns. You know what I mean? And like, she started laughing. And then I was like, it just got a little bit of cavity under it. It's no big deal. We'll replace it, clean it up, and put a new one on. And, she scheduled, no big deal. And it just made it like easy and straightforward and seem matter of fact. And just, that's what happens to dentistry. It needs to be replaced. And look at how many thousands of meals you ate on these crowns. So it was just fun. She started laughing, and like, she had to think about it. Like, did I really eat 20,000 meals on these things? I'm like, yeah, you did. And then she wasn't expecting it.
I like that you told her to buy that dentist a beer. Like, I think
that's like I've been using that line, like the thousands of meals with the beer, like every time.
That's awesome.
So you really owe that
dentist a beer. No, that's fantastic. And it's like little things like that just kind of break the ice. Like a little bit of just like humor in your case presentation can make a big difference.
Yeah. And like Paul's thing of like, we can still be friends. You know what I mean? Like the I'm breaking up with you type thing. Like, I haven't tried that one yet. I'm kind of excited to, but I'm also a little like, I feel like I didn't totally get it the first time you said it. So I'm just a little bit apprehensive. I got to be the right situation with the right patient to try that one out first. But I'm excited for it.
It's just like one of those, like, you can preface stuff. I don't think it like has to be like a breakup thing, but it's like one of those, like, giving them permission to say no right up front and still like feel zero pressure about it makes whatever you say next a whole lot less like angsty and filled with like, oh, this looming recommendation that my dentist is about to give me.
True. Yeah.
Let me think. Anything else that we missed there? Just great language overall.
Mindset on implants. I think, Paul, I think we had a good conversation of bridge versus implant in the episode. And kind of one of the things that, having been a couple weeks since we recorded it, in my conversations with patients, I'm just much more recommending one solution for missing teeth as opposed to recommending multiple. As like, maybe recommending one is the best. You know what I mean?
It's almost like you recommend a bridge, but you really don't want to do the bridge. And then you have to talk them out of the bridge when they accept the bridge. And you're like, okay, just to make sure this is a bad option, but we're going to go for it. It's not that it's bad, but it's like, if you not as good.
Not as good.
And so providing upfront the one tooth solution to the one tooth problem and seeing if they'll accept that is not a bad way to go, rather than giving them like 5 options that 4 of them you don't really like. You only like one of those options. We'll start with that option and go from there.
Yeah. And in those consults where I talk about that, I've been mentioning like, you still got 50,000 meals to eat on these teeth, so I think it could be used both ways. It could be used as for a younger patient, that, they have a good amount of life left, to kind of talk to them about it that way.
Perfect. I just love me some nachos. I love me some Dr. Paul Goodman. It's funny to me to see, like, I know people see him online everywhere and they need small breaks at times because they're just, it's too much nachos for them to handle. It makes me sad when I see like my like dental idols fight online, and they like go at it. So don't pick a fight with Paul Goodman. He's very polite. He's very nice, and he'll offer you nachos. Just let him do his thing.
That's so dentist.
That's so dentist. All right. Okay, we'll wrap it up. This has been an awesome episode of the Shared Practices podcast. We'll talk with you guys next week. Talk with you guys next week.